Ready.
All right. Hello, everybody. With our efforts to start on time, we're going to go ahead and get going. As people come in, we'll welcome them in the room. So for those of you who don't know me, I am Allison Agu, and in this role, I am the program director of the Ryan White Johns Hopkins Women, Infant, Children, and Youth Partnership for Excellence across America, Central Maryland. And this is our Part D virtual toolkit series. And as you know, if you've attended before, the goal of this toolkit series is to engage and amplify. Next slide. So briefly, for those of you who don't know about JH Wiki, we are comprised of 6 distinguished programs. We're 4, now 6 with our renewed application. Several programs at Johns Hopkins, but also programs at Sinai and the University of Maryland. And the vision is really to achieve a more coordinated response to HIV by cultivating mutually beneficial relationships between ourselves and our community of providers to increase the quality of care that we provide as a community, and to build upon those existing structures and systems to create a dedicated network of providers to coordinate across multidisciplinary systems of care. And again, the goal of this series and the goal of our network is to engage and amplify our local experts. This is when I say, if you see something, say something. If you do something, say something. We want to amplify your voices as well, so that if you have something to share, we'd love to feature you on our toolkit series. Next slide, Marinas. So today, it is my absolute pleasure to introduce my friend and mentor, Dr. Kelly Gebo, who is an infectious disease specialist, adult, epidemiologist, and her goal is to talk to us about monkeypox. I think some of us think monkeypox is over. It is not. To understand clinical presentation of monkeypox and what's special about the 2022 outbreak, describe useful supportive and antiviral therapies, and to think about appropriate candidates for antiviral treatment for monkeypox. Next slide. Briefly about Kelly Gebo. So as I said, Kelly's a professor of medicine and epidemiology at Johns Hopkins. She has spent her career developing large HIV observational cohorts and studying healthcare utilization, cost of care, and clinical outcomes in individuals living with HIV locally and nationally. She was formerly the co-principal investigator of the HIV Research Network, where I met her and did a lot of my formative work, and is a site PI for the North American AIDS Collaboration on Research, or NA Accord. Again, one of these large networks that is provided sentinel analyses on HIV care and outcomes, and was an inaugural chief of the medical scientific provider of the All of Us project. However, Kelly has pivoted in recent years and done significant amount of work along with Dr. David Sullivan on early treatment of outpatient COVID-19 using antibody titers, and has really led the JHU research agenda for monkeypox. It is my pleasure and my honor to introduce my friend, colleague, and mentor, Dr. Kelly Gebo. Take it away, Kelly.
Allison, thank you for that very generous introduction. It's my pleasure to be here today, and really appreciate the opportunity to come and speak with you all. Allison has been the invitation and to really see the great work that she's leading. So we're going to talk a little bit about Monkeypox 2022 and what's happening currently. I'd be happy to entertain questions, so please feel free to put things in the chat or raise your hands. I'm happy to make this interactive if possible. These are my disclosures. Before we get started, I'd like to acknowledge all of the people who have been involved in Johns Hopkins efforts with monkeypox, and particularly the ones, the investigators who are listed on this slide: Liz Gilliams, Heba Mustafa, Joyce Jones, David Blythe, Jason Farley, Jason Zucker at Columbia, who have all been very gracious in helping share slides and other information between our research protocols to get things out to the communities. So I'd like to start with a presentation of a patient that I saw in the summer this year. It was a 32-year-old gentleman who was in his usual state of health until 1 week prior, when he developed cough, myalgias, fevers, and chills. And 3 days prior to presentation, he developed a rash on his face and on his only history. And he had been on Xolair, which is a IgE-mediated drug to help prevent that. He cares for his elderly grandmother who lives with him. He's a healthcare worker who's very active. He had been on a cruise recently. He used no tobacco, alcohol, or drugs, but is very physically active, running marathons and doing a lot of exercise. On exam, he was his entire exam shoddy inguinal lymphadenopathy, and 2 lesions, 2 areas that we saw lesions. These were not, but these are representative of umbilicated lesions, both on his face and at the base of his penis. So the questions that came up for him are, what do we do in terms of diagnosis? What should we do for treatment? And then what happens about returning to work and at home? So just as a brief overview, monkeypox is an orthopox virus. And with the eradication of smallpox in 1980 and with the cessation of smallpox vaccination, we have seen more cases of monkeypox which have emerged, usually in Central and West Africa. And these have often been in proximity to tropical rainforests, but it's now been appearing in urban areas. And we've seen a global explosion of this in the past 6 months. There are a number of animal hosts for this virus, and you can see some of them here. And there are two specific clades, clade 1 and clade 2. One is from West Africa, clade 1 is from Central Africa, and there's significantly different mortality rates. Clade 1 has a much higher mortality rate of about 10%. We are seeing what we think is, what we're identifying as clade 2B here in the summer of 22 pandemic that we're seeing. And this is the most recent data that was on the CDC website, and it shows that we have 78,000 cases that have been seen globally and approximately 40 deaths. You can see countries with orange dots, and the orange dot represents roughly the size of the outbreak in that country. And then the blue dots are where it is endemic in those nations in Africa. This is in the there were 6,000 cases. That the Maryland region has about 700 cases, with DC close behind at 522. So DC was disproportionately impacted compared to the Maryland region. The second largest county in Maryland was Prince George's. And thankfully, what we've seen is a trajectory of new infections peaked in sort of the first week of August, at least in the United States, and then has come down pretty dramatically, where you see just the tail end of this curve with very few cases currently. This is showing some demographics of monkeypox according to race and what has been seen here in the United States. And what you can see is the blue bars are whites, the green are Hispanic, and the purple are Black or African Americans. And with the initial weeks of the pandemic or the outbreak in the United States, you saw a disproportionate number of whites, and then that has come down with an increasing number of Hispanics and particularly Blacks and African Americans. In addition, there's been a lot of discussion amongst the populations who are thought to be at greatest risk. This slide looks at the distribution of age and gender, and you can see that the blue is men, orange is women, purple is transgender men, the light blue is transgender women. You can see the overwhelming majority of these cases in the United States are men and the younger age groups, so generally between the ages of 21 and 41. In terms of clinical presentation, this is what we're seeing currently. Skin lesions are typically fluid-filled. They can be vesicular or pustular. They're deep-seated. They can be umbilicated on the top, as you can see here with the, it looks like a volcano. They're often painful, and they can have itching or crusting during the early phases. The lesions usually resolve in 2 to 4 weeks after appearance of the symptoms, and in general, most cases that we're seeing currently have about 10 lesions. This is in contrast to what has been seen in Africa, where there can be thousands of lesions. They tend to appear all at the same time, and they often are on the palms and soles. You can see on the extremities as well. This particular outbreak has seen a lot more genital lesions, particularly on the anus, the rectum, and on the penis. These are some photographs that were taken from a London, UK STD clinic. And you can see that these are in incredibly painful locations because of the mucous membranes, as well as because of the frequent defecation or urination, and that can really impact the pain that patients are feeling. In terms of differential diagnoses, it's important to think broadly. Many infections appear in places that could be many different types of illnesses. So while there are patients who present with a classic story for monkeypox, it's important to keep your differential wide. And what you can see is that these lesions are appearing in very different places on mucous membranes, on different organs, as well as in different regions of the body. And as you think through what can present with genital ulcers, it's important to keep a broad differential. We tend to think, I think, in diseases, and LGV. In terms of proctitis, we have a number of patients who present with tenesmus or proctitis symptoms, and it's important to test for GC, chlamydia, and HSV. And then for people who have rashes, it's important to think about lots of different types of vesicular or umbilicated rashes, not only virus or bacterial illnesses like herpes, varicella zoster, syphilis, molluscum, but also hand, foot, and mouth disease. And there have been several instances where monkeypox and hand, foot, and mouth have been confused, particularly in children. These are 4 large studies that have been recently reported in the past few months from a variety of countries. And what I'm going to do is compare and contrast how the outbreaks look in those different countries. So the first case was from the Lancet. It has about 200 cases in Spain. The next was about 200 cases that were in London in the BMJ, about 500 cases by Chloe Orkin in the New England Journal in 16 countries. And then the data from the US, from the MMWR, published by the CDC, had about 1,200 patients reported. And as you can see, in almost all the studies, nearly 99% of them were male. There was a few transgender patients who were affected as well, but relatively few females in all of these studies. In addition, almost 100% of the patients had lesions with more involvement of the mucous membranes, both the oropharynx, the rectum, as well as the penis and vagina. We also saw that there was fewer lesions, and they didn't seem to have the same type of uniform presentation. So in traditional monkeypox, patients present uniform lesions. They're all evolving at the same pace, and that was not what we saw with this particular outbreak. In terms of involvement of other organs, about a quarter of the patients that were studied in these various different studies had rectal pain or involvement of the rectum. And about half to 3/4 had involvement of the genitals in some way. This could include anal or perianal involvement, vaginal for women. And you can see that about half of these patients had evidence of it on their trunk, with a significant distribution on their hands and feet. So there was about a quarter. And then about a quarter of the patients also had perioral or oropharyngeal lesions. It's important to think about monkeypox not just in those who have symptomatic vesicular lesions, but also it's been shown to appear in asymptomatic men. So these were 2 studies, one from Belgium, one from Paris, France, which showed between 1% and 7% of asymptomatic men who were presenting for screening for asymptomatic testing had the monkeypox virus in their rectums that was culturable. So this has significant ramifications in terms of transmission if we have men who are asymptomatic who are actually able to spread this virus to others. In terms of diagnostics, this is Dr. Heba Mustafa, who's one of our leading virologists here at Johns Hopkins, has been instrumental in both the COVID pandemic as well as the monkeypox endeavors, and has helped with launching a PCR swab, PCR, which is done from a swab, and the results are obtained very quickly. There are a number of commercial labs that also allow for monkeypox testing at the Baltimore City Health Department. Virology is available, but not easily obtainable, and we are not generally recommending that for patients at the moment. One of the things to think about is how to obtain specimens safely, and this is much like COVID, where providers need to protect themselves, so to double glove, to gown, to wear a face shield, and to make sure that everything is being done to, and a mask, obviously, to prevent transmission from patient to provider. There have been cases that have been shown to happen, generally with a needle stick. So it's important that providers do everything they can to protect themselves while they're obtaining these samples. In general, we were puncturing the lesions early on in the pandemic. We're no longer doing that, and we're swabbing them aggressively. It's important to rub very vigorously to try to make sure that you're getting as much of the study material off the lesion as possible. We generally recommend doing 2 to 3 lesions, and this goes to the lab in viral media. The CDC has indications, and there's infographics on how to obtain the specimens. There's actually a video as well. In general, the turnaround time at Johns Hopkins is about 24 hours, which is really truly remarkable. Specimens are taking a longer period of time if they're going to the city or state. And positive specimens are then sent to the state health department for confirmatory testing, and a subset of those are sent on to the CDC. These are 3 wonderful investigators who have been helping us think through diagnostics here at Johns Hopkins in terms of trying to obtain specimens from other sources other than the lesions. And there's been discussion about both rectal and oral swabs. As you've seen, there have been studies that have shown asymptomatic shedding is occurring. Looking at urine, blood, and genital fluids are also possibilities. not obtained for clinical reasons, but in the research realm. So what do you tell a patient who has been swabbed and is awaiting the results? It's important for them to isolate at home because they are potentially transmissible. It's important if they live with others to try to stay in a separate room and to wear a mask when in the presence of others and keep their lesions covered. It's important to avoid contact with animals. There have been reports of transmission from patient to dog. It's important to remind people to use hand hygiene, particularly in areas where they could be sharing with other people who are in the home, such as bathrooms, and to make sure that you're cleaning everything with appropriate antiviral cleaning products. You should avoid sharing bedding, towels, and clothing with anybody else while you have active lesions. Using a standard washing machine is perfectly fine. It does not require extra bleach to clean any of these clothing materials. It's recommended to not share utensils or dishes with others while you have active lesions, and to make sure that you wash them between uses, between people in the same home. And then cleaning any contaminated surfaces, as we mentioned, with household cleaners and disinfectants. If you have a positive test, as our patient did, what do you do? Well, the good news is almost all patients recover without complications, and that's important to reassure patients about. There are things that we can do for symptomatic treatment, and we're going to be talking both about supportive care as well as antivirals. The health department will be notified, contacted by the health department. Hospital days occur rarely, and when it does, to be in a disciplinary way. A lot of patients have involvement of their eyes or their rectum. They can get bacterial superinfections, and so it's important to have collaborative care from other consultants. For our outpatients, the Baltimore City Health Department will be contacting patients. They'll get a call from the acute communicable diseases team, who will try to do contact. Patients have available information regarding their contacts. The health department will do their best to track them down. We'll talk a little bit about vaccines and how they're administered and why it's important to do this contact tracing as early as possible. And then they will also help with when patients can be released from quarantine. They help to talk through illness issues such as homelessness, shared spaces, and public transportation, all of which are relevant because these lesions can last for up to 3 weeks. So unlike COVID, which asks you to be home for 5 days, if you're asking patients to isolate for up to 3 weeks, this can have significant ramifications, both in terms of their general home life, as well as their financial situation. The symptomatic treatment, we try to follow the guidance that was given by the CDC, where a Dear Colleague letter was sent this summer about assessing pain. And pain is one of the most prevalent symptoms in our patients. And it may happen in patients who may or may not have lesions that are visible. So patients can have lesions either in their oropharyngeal area or in their rectum that we can't actually physical exam, but it doesn't mean that their pain shouldn't be controlled. And there's multiple supportive ways to do this. It's important to stay in contact with patients because their symptoms can wax and wane. So making sure they have adequate pain. Antivirals may be an indication, pain control may be an indication for actually using antivirals, even if their disease is relatively well controlled. In terms of supportive care, for those of us who have treated HIV and some of the erosive esophagitis we have seen in the past, the magic mouthwash, which has Benadryl, lidocaine, and milk of magnesia, can often be symptomatic relief. Saltwater gargles and viscous lidocaine are also helpful and have been used in a variety of places. In terms of rectal, do you see my screen?
Yes, it's back.
Yes.
Okay. Sorry, I don't know what happened there. In terms of rectal lesions, stool softeners are important. Some patients try to hold back on defecating because it's painful. They have to help softening stool to reduce the pain with passage of stool. Sitz baths and topical lidocaine can be useful. Gabapentin can be helpful. In general, avoiding opioids is important because this can lead to constipation, which can increase the pain with defecation. And then in terms of genital lesions, it's important to change your clothes frequently to keep the areas clean. Bacterial superinfection is very common. And the inguinal adenopathy that can occur can often be a source or a place where sometimes there's erosion over the skin. Generally avoiding topical steroids because any immunosuppressant can flare the disease. And then using nonsteroidals with caution, particularly in patients who have evidence of erosive disease because you don't want them to bleed. In terms of antivirals, there's a number of different antivirals that can be used. Cidofovir and brincidofovir are used much less commonly. Tecovirimat is the most commonly used right now. And there's a web page that was just updated last week for treatment for healthcare professionals on the CDC website. I'm going to hit a couple of the highlights of that web page. Brincidofovir was used in initial outbreaks in the summer and in England. This is data from 3 patients who were treated as part of an outbreak, and you can see, had increasing LFTs to very high ranges. In fact, all 3 had to be stopped from their therapy prior to completion of the treatment because of these increasing transaminases. That said, we do have some patients who are unable to tolerate tecovirimat or a progression on tecovirimat. So it's been recommended to use brincidofovir for patients who have severe disease or a high risk of progression and have had progression on tecovirimat or are not improving, or if they have a contraindication or have been unable to tolerate tecovirimat. So this is rarely used. The CDC can provide it. I have information at the end of the slides on how to get it if you actually want to pursue it with the CDC. Tecovirimat is the most commonly used drug right now. It's available on an EAIND, so it's not an FDA-approved agent, but we have ways to obtain it both here at Johns Hopkins and then nationally through this CDC protocol. It's taken either orally or intravenously twice a day for approximately 14 days, and it's recommended to take it after a full-fat meal, approximately 30 minutes. One of our patients said it's the only time that he's had a provider recommend that he take his meals with bacon. And while we have limited efficacy data, it does suggest that it's actually working. And there's been data recently reported from the CDC, which has shown that it's been tolerated quite well. So in general, we are trying to get some more data. Data. This is again data from that same cohort in the UK, and what you can see is that this patient had samples from a variety of different sources, and they were viremic. They started tecovirimat on day 4 and immediately became suppressed. So they had no virus that was obtained either in their upper respiratory tract, their blood, or in their urine. So in terms of indications for antiviral treatment, it's important to think about people who have severe illness. So anybody who's hospitalized, who has sepsis or viremia might want to consider it. People at risk of severe disease, and these include those with severe immunocompromise, including patients with advanced HIV, leukemia, lymphoma, or other types of malignancies. People with exfoliative skin disorders, particularly atopic dermatitis, children under the age of 8, pregnant and breastfeeding patients, people with complications such as bacterial infections, or those who have illness complications. And this can include infection, but also uncontrolled pain. And we do see complications, including encephalitis, rectal bleeding, and proctitis. So in those patients, this would be an indication. And then those who have lesions in anatopic areas that could constitute, like eyes, mouth, genitals, or anus. Unfortunately, the complications when they occur are severe. We have seen several of our patients who are admitted to the burn unit at Bayview for a variety of different complications, and proctitis, urethritis, pharyngitis are all ones that we see more commonly. Lymphadenopathy is reported. The erosion of the skin can happen for significant lymphadenopathy, and this is often resulting in bacterial superinfection. Encephalitis is relatively rare, but has happened in very immunosuppressed patients. And one of the things that we're trying to learn more about is scarring in terms of what happens to patients with the current lesions or the current clade, and to see if they have the same scarring that has been reported in previous clades. In terms of overall advice, once somebody has tested positive, I talk to them about there are treatment options, both supportive and antivirals, and we talk through what are the options for them. It's important to separate themselves from their family members in their home if possible. If they do leave their home, to cover their lesions, and if possible, to avoid work. Some people are unable to do so, and if they have to go to work, we recommend that they do everything they can to cover their lesions. They not share their towels, bed linens, and to wash them separately, as we discussed. Not to use contact lenses because you do not want to auto-infect your eye as you're putting it in if you have any viral particles on your hands. And then one of the questions we often get is, when is it safe to have sex again? The WHO recommends 12 weeks after recovery and using condoms. Up until then, we don't know how long it is in the genital fluids. It's one of the things that people are currently looking at. And so it's important to tell people that they can have sex, they can have safe sex, using a condom until they have adequately recovered, and 12 weeks beyond that is what we're recommending. So I'd like to shift a little bit to talking, instead of acute management, to talking a little bit about prevention and thinking about vaccines. There are currently 2 vaccines that are available. The ACAM2000, and some of us who are old enough may have received that. This is a live replication-competent vaccinia virus that was 1 dose, and it's done with a bifurcated needle. It's also EA-IND for monkeypox, and it should not be used in people who have evidence of immune deficiency or atopic dermatitis, but there is a risk of household contacts and vaccinia transmission. The Jynneos vaccine is what's been rolled out recently. This is a live, non-replicating vaccinia virus. It requires 2 doses, which are given 4 weeks apart, and it's ideally that you would have optimum antibodies 2 weeks after that 2nd dose. It is it's FDA approved with for those 18 and over, and it's available on an EA-IND for children who have been exposed under 18. We're currently learning about what the data is on the efficacy, but we don't have a lot on that currently. Contraindicated in people who are actually having monkeypox symptoms, those with a severe allergy to eggs, ciprofloxacin and gentamicin. And it's safe to administer to people who are living with HIV, which I think is really important given the populations that have been exposed. Who should be recommended for vaccines? Well, anybody who's been exposed, so people who have post-exposure prophylaxis, so either sexual or household contacts of active cases. If it's given within the first 4 days, it's to prevent disease. If it's given between 4 and 14 days, we hope that it's going to reduce the severity of a case if it develops. And we're also considering pre-exposure prophylaxis, and for people who have high risk. So men who have sex with men with multiple partners, commercial sex workers, research and lab workers, some healthcare workers and response teams have gotten the vaccine. And then anti-terror authorities have also been vaccinated. In terms of stigma, this is one of the most important things to think about. I think this happens fairly frequently. And for those of us who have taken care of patients with HIV, this is not something to underestimate. And for those of us who have had patients who have died from HIV, particularly in the 80s and 90s, we know that shame when they were ostracized from their families and friends because of the disease, and it's thought to be related to their behaviors. And I think it's really important for us to think about how do we manage patients and their families in this particular situation. And this was a very moving piece that was written in the New York Times this summer. For those of you who haven't read it, I'd recommend it. It highlights the stories of 7 patients who had monkeypox and the shame and stigma that was associated with it. And so this is a story from a patient who was trying to be evaluated for what he thought was monkeypox. And he called his doctor, who urged him to call a primary care provider, who told him to go to the health department. They told him to go to the emergency room, and then when he pushed back, they suggested he go to another local clinic. And when he arrived there, he found the doctors and nurses waiting in the gear that we wear, right? The prophylactic gear that we wear to protect ourselves. But you can imagine if you're a patient, it feels like people are coming from outer space, and it can feel very isolating, as if they have the plague. We heard this with COVID. We have seen it in previous diseases when you come in with a gown and gloves and a helmet, and it can appear that you don't want to touch or feel or be next to somebody because you're at risk of transmission. And he said that the medical staff stood in the doorway and spoke to him from a distance. They had these hazmat suits. It felt like it was very sci-fi. And he commented that monkeypox triggered painful memories. And I think for those of us who have cared for patients, it's important to recognize this. So warning patients before they come in that this is how they're going to be tested. And it's not because we're concerned, but we're concerned about transmission. And so we are going to test them. We're going to treat them with care. We're going to sit with them and talk with them, and we're going to touch them. We are going to sample their lesions. But this is to protect ourselves and to keep things safe. And I think when explained in that way, it can be done in a touching and empathetic way. But when patients are just thrown into a room without the understanding of why people are coming and going with these hazmat suits on, and that they're going to be swabbed and sampled without understanding, I think that's a real issue. The other thing is that there's a lot of stigma that goes associated with this, because many patients who have monkeypox may not be out to families. And so thinking through that when you diagnose a patient, how will they communicate this to their family members, to their place of employment, if they're not out at their place of employment, and how to help them with that conversation. So FMLA is very useful in helping patients to be out of work if possible for them, and thinking through ways to help reduce internal stigma that we might not think through as we're kind of working about making sure that they don't get it into their eyes and making sure that they have all the samples taken that need to be done. But making sure that their emotional care is taken care of, I think, is equally, if not more important for patient care. Well, one of the other things that we've seen with COVID is that there's often not vaccine equity, and demand outstrips supply, at least at the beginning of this. This is a photo from the Chelsea Health Clinic in New York City, and you can see a lot of men standing in line to get vaccinated, particularly when there wasn't a lot of supply available. That has been rectified, and I'm pleased to see that that is making progress. But unfortunately, the cases of monkeypox and the vaccine distribution have not been what we would hope to be in terms of distribution. So the table on the left shows the total number of monkeypox cases by race in New York City, and you can see that there's a significant increase in Hispanics and Blacks between July and September, and 70% of cases were among Blacks, but much fewer of the vaccines were given to Blacks, about 24%. And there's many reasons that are thought to be as a result of this. In some communities, having sex with men is not thought to be an acceptable behavior. And so many patients don't want to receive a vaccine or don't want to go to a place where they're going to be vaccinated, where it could be identified that they engage in gay behavior. And so there have been a lot of stigma associated with receiving a vaccine. So the CDC has rolled out an innovative approach to this in terms of a vaccine equity pilot program, where they were able to give vaccines in a variety of different situations, ballrooms, bars, parties, and a number of situations. There actually was an article in the New York Times today about how they're closing down some of the vans that have been going out to these parties to give vaccines because they have been, they feel that they've given out a fair amount, and the outbreak has slowed dramatically. But I think this was a really innovative way for the CDC to approach ways to give vaccines to populations that don't want to be identified by going to an HIV clinic or a sexually transmitted infection in a way that was both responsible. And I think it was generally very well. It'll be interesting to study the efficacy of this moving forward, and if this is a way that we can potentially administer STI or HIV care or other ways to deliver care to populations that are potentially ones that have been stigmatized and ones who are not potentially interested in coming to a vaccine, to a clinic where they can be further, they feel more stigma. So in summary, in terms of the patient, he was treated with tecovirimat. He was back to most of his normal activities fairly quickly. His rash resolved, and he was back to work in about 3 weeks. One of the issues that did come up was what to tell his family, and he ended up disclosing that he had a rash and that he couldn't take care of his grandmother, so she went to another family member. He ended up disclosing to the grandmother because she had to be vaccinated. And so that precipitated a challenging conversation, but I think was helpful to him. He ended up not disclosing to his place of employment, and he was able to get back to work in a way that was, I think, safe for him and for the patients that he cares for. It's important to think about these, help patients be able to communicate this effectively. And the other thing was he was able to notify his other partners and they were able to be vaccinated as well. So in conclusion, monkeypox is not presenting classically, but is presenting as a sexually transmitted infection clinics and HIV providers and EDs. At Johns Hopkins, we're seeing the highest number of testing patients in the Bartlett Clinic and in the emergency department. I've neglected to mention that when a patient presents with these lesions, they should be tested for all of the sexually transmitted infections in terms of gonorrhea and chlamydia and triple site testing. They should have a syphilis test sent off, as well as HIV testing if they're not known to be positive already. It looks like other STIs, and so the history and physical can be helpful in the differential, but it's better to test than wonder, and it's important to test for all of the sexually transmitted infections as well as the concomitant HIV testing. Supportive care is important for all patients, and it will be enough for most patients. Antivirals are available, and when needed, it is important to give them. And I think we've had really good success with doing that here at Johns Hopkins. It's also been able to be rolled out at a variety of different sites, and I'm really pleased that the health department and University of Maryland and a variety of other sites within Maryland, as well as nationally, have been able to provide this treatment to patients who need it. And I think thinking through a multidisciplinary team to make sure the patients know that they can call at any time, that there's a provider who's understanding and knows what monkeypox is, and that when needed, they can have referrals to surgeons, whether they are urologists or some of our rectal surgeons, or potentially EGD and EGD by our gastroenterologist for people who have oropharyngeal lesions. And I think it's important to consider pain management and making sure that patients have adequate pain control. So for patients, particularly ones who are admitted, making sure that they have adequate involvement from the pain control teams. I think there's still a lot of questions we don't know. Does the previous vaccine confer protection? And we don't know that. A lot of studies are being done to try to look at this data. Does Jynneos vaccine actually convey protection? We gave it to a lot of people during the summer, and it'll be interesting to see if that helps with stemming the tide. We have seen the rates of monkeypox drop dramatically, as I mentioned. And I think that this is multifactorial, both from changes in behavior in the gay community and in others who are at high risk in terms of doing things to limit their sexual networks, to engaging in safer sex, to reducing their risk by having barrier protection. And I think that this has helped with decreasing the rate. I also think that vaccines have helped with that. What we're trying to figure out, and there's some studies looking at this, is what is the impact of each of those? Does tecovirimat improve outcomes? And there's a study here at Johns Hopkins as well as nationally in the ACPG to look at tecovirimat being randomized to the drug versus not. What is the role of asymptomatic infection? So clearly we've seen men who have rectal shedding. Does it happen in women? Are we seeing it in other sources? What is the scarring going to look like in our populations? When can people safely go back to work? When can they engage in sex? And how long does it persist in genital fluids? So lots of really important, interesting questions that we don't know the answers to, and we hope to in the coming years. There's a number of additional resources available here, which I realize are for Maryland, but are available to others. And also this is for the brincidofovir. There's a CDC email for difficult cases, as well as a hotline if you want to get brincidofovir from the CDC. And then I put some information here in terms of registration for vaccines, both here in Baltimore and at the state level. In general, we are trying to get the vaccine launched at Johns Hopkins. They have vaccine. It's not currently available yet because we still have to get the order sets ready, but we hope to be able to do this in the next few weeks. And I think this will be an important mechanism for us to try to continue to prevent this outbreak from increasing moving forward. In conclusion, I want to acknowledge the patients who have graciously shared their stories and samples with us, and we are very grateful to the clinicians and compassionate providers who have really stepped up yet again, despite the risks themselves, and to many others when we didn't know a lot about this disease, particularly in the summertime. And then 4 groups that have been really helpful in sort of launching this are the Bartlett Specialty Practice, the Johns Hopkins Center for AIDS Research, the Baltimore City Health Department, and the Johns Hopkins ICTR. I'd be happy to entertain any questions. I appreciate your time and look forward to a little bit more discussion.
Okay, that was fantastic. Thank you. A tour de force of everything, and your expertise was showing. I have one quick question. I see a question in the chat. My question was about the lesions, and it's a 2-part. One, how long-standing do we know the pain can go on? Like, how long does that go on for individuals who have had really intense lesions? And 2, do we know about keloiding and scarring related to the lesions?
Yeah, so related to your second question, that's a really important issue that we're sort of looking at. You know, we know that there was scarring that occurs with the other clades. We anticipate that there will be some scarring, and I think what we don't know is, are different groups going to be at higher risk? So people who are more immune suppressed, and so do they have a higher risk of scarring? Are there differences by ethnicity? And so in different racial groups, are we going to be seeing that as well? So we're doing some evaluation of patients who came to Johns Hopkins to look at scarring, and I know that there's efforts to look at that sort of more nationally. Yeah. But I do think that there's concern that in immunosuppressed patients, there's going to be more likely to have deeper-seated infections. And your first question was about
the duration of the pain that people have. How long
pain.
does that last?
Yeah, you know, it's an interesting question, and it often relates to how much of the mucosal involvement they have. So the lesions on the skin tend to be not as painful. It's the one on the mucosal membranes. And so oropharyngeal and rectal lesions tend to be the most painful ones, eye lesions also. And so it's important to try to get those patients on therapy. And we have found that that's been an important mechanism to help try to reduce the burden. But pain control is a really difficult one, particularly in men who have issues related to the urethra, and they can be on the shaft of the penis or inside the urethra itself. as well as ones on the rectum.
Yeah, great. There's a question, and Marianne, your age is telling in this one. Marianne is asking if you could address the need for vaccine for those who received smallpox vaccine in the past. A great question.
It is a really good question. And, this came up in a number of the trials, particularly the MAX trial, which has a number of gay men who tend to be a little bit older, and trying to look to see if they are seroconverting or if they had decreased risks of monkeypox. So we don't know the answer to it. And it's one of the things that we're currently investigating with data that has been collected this summer on populations. So looking at what were the antibody titers prior to monkeypox in terms of, those particular study groups, and then seeing after the outbreak, how many of them seroconverted, how many of them were vaccinated, and how many of them were able to prevent disease. So to be coming, but we don't know the answer yet. Or at least I don't know the answer yet.
Yeah, that's a great question. I am a bit curious. I think we were all worried, and the efforts to sort of curb the monkeypox epidemic, I think, were really robust. But I'm wondering if is it something that we did, or is it that maybe monkeypox is one of these climate change pathogens that peaked because the summer was warm and robust, and now it's gone away. Just curious. I know you gave some theories, but just is this one of those climate change things we're seeing, and maybe we may see it next year? Or wonder if you can comment on that.
Right now in the South, Brazil and other places have seen a huge explosion in the number of cases that are currently occurring. And we don't know if it's because they're on a different level than we are. And, it's unclear why that's happening. I think the good news is that both vaccines and I think changes in behavior help. But I would suggest that we need to keep our ear to the ground. It's been suggested, and I don't have any evidence to back this up, but this might have been circulating for a long period of time before we actually became more clinically aware of it. And that with COVID, people had fewer partners. So some of the undiagnosed STIs that we saw previously may have been monkeypox, and we just don't know it. So some of these cases we saw of people who had lesions, which we couldn't quite figure out what they were. It might have been that they had a monkeypox outbreak, and this had been sort of percolating subclinically. So there's a lot of speculation as to how long this has actually been out in the community and what caused the June or early summer explosion that we see currently.
I guess the other question I had was really, thank you for highlighting the comment, the issue around stigma. And I think we oftentimes don't think about how we can participate in perpetuating not just stigma, but trauma that comes into care. And I think important for us to think about that as well as the other things that we see. And I really appreciate you highlighting that. I wonder because not everybody here is from Hopkins, in terms of the studies that you talked about, we're looking for people, some are just questionnaires about their experiences with monkeypox. Is that available for people who were seeing it outside places, or how can people reach out to you if they are available for themselves?
That's a great question. And currently we've got the IRB approval for Johns Hopkins patients, but that's a really good point that we could potentially roll this out more broadly. And I know Jason Farley and others have been trying to think about that. So if providers or others on this phone call are interested, please email me and we can try to get the IRB adjusted accordingly. And we are trying to collect biospecimens as well for patients to see, both for vaccination as well as for those who've recovered. So some of the things we're going to be looking at moving forward are both the stigma and some of the issues that patients faced with the acute illness, and then the long-term consequences, both in terms of scarring as well as issues with loss of friends or family, or issues with difficult relationships because of a monkeypox infection.
Yeah, great. Well, I'm going to make sure I'm talking a lot because any other questions people have? I have one more, but
yeah, I was going to ask. Thanks, Kelly. David. I had a few patients who, we found the lesion in the visit, and they were kind of, monkeypox wasn't on their radar at all. And I had one patient who, for history, had monkeypox and recovered from it, and then saw me and described these weird bumps that he had that got better. And this is in the midst of the peak when it was all over the media. So I'm just, a lot of our younger patients just aren't in tune with a lot of that public health messaging and the media messaging. So I guess is it, what is we as providers, or what messaging is it about, asking every visit? But now that the cases have gone down, just how do we do the messaging better? Because I really think we're hitting the high information folks, but I don't know, a lot of our patients just, it's just not, they're not even thinking about it. So how do we help that?
No, I think your points are right on target, David. And you know, ironically, what we saw was a number of people who were being vaccinated were older people, often who had had smallpox vaccine, and who were really not at risk because they were either in a monogamous relationship or not considered to be high risk in terms of multiple partners, et cetera. And so I think you're exactly right. And one of the things the CDC tried to do with this vaccine equity project was bringing the information to populations at risk. And so trying to go to LGBTQ events and trying to go to places where patients were, and they were known parties or known bars where there had been circulating virus. And I think, you know, it's hard to do that in real time because you don't know who's infected, but there was a lot of work in New York City and in other groups to try to have that happen. That said, I think your point is very reasonable, that those tended to be higher socioeconomic status, more well-educated men in general. And making sure that we are bringing the messaging to communities of color and communities of lower health literacy is on us. And we need to do a better job with that. And so there was a number of initiatives through Facebook and other things to try to engage populations that are younger. But as I think you and Allison and others have pointed out to me, that people my age use Facebook, people who are 20 use Instagram and a variety of other places. So it's a good message for us to be thinking about and trying to make sure that if we do use social media, that we use the right social media. And in the survey that we have for Hopkins patients that we're looking at, one of the questions is, what social media apps do you use? Because we're trying to identify, you know, what are the ways that we can better communicate with patients, because I think it's going to be an important thing moving forward.
That's great.
We have to make TikTok videos.
I was just going to say, you need TikTok. Well, maybe TikTok's not cool anymore either. I don't know.
I know, right?
Yeah.
Ask Aaron what we should use, even though Aaron's getting old too.
That was so summer. We're now in fall.
Awesome. Well, any other questions before we release? All right. Again, Kelly, that was fantastic.
Thank you.
This will be available
for inviting me.
Yeah, no, definitely.
And should there any questions, please feel free to email.
Yes. So as usual, we're going to be sending these out. And as you all know, we are forming, what is it, a YouTube channel or Facebook? This will be available online so people can access if you want to reach out and if there's more questions. There will be a post survey as usual to get your thoughts or feedback, and again, about other things you may want to share. Thanks again, Kelly. Moving forward, December 1st, we actually have a special episode for World AIDS Day, looking at our own breastfeeding program. We've presented other places, but not to our local community about our breastfeeding program. There's a lot of questions. And so we'll have our multidisciplinary team, as well as likely a young woman who has experienced the Hopkins breastfeeding to share experiences. So please do invite your friends and come along with that. And with that, I will pause and wish you a wonderful rest of your day and rest of the month, including the holiday season. Thanks, everybody. Bye-bye. Thanks again, Dr. Gebo.